think people are going to continue to filter in. Good morning, ladies and gentlemen. Please go ahead and take your seats. Good morning. Good morning. My name is Reverend Colin Knapp, and I am the senior pastor of this church, Pilgrim Congregational Church. This is Pilgrim's 150th year in existence, and so as a part of that milestone, we are celebrating throughout the year with a number of special events like this one. Part of why an event like a health equity panel is important to our community is because we are a community of faith that is committed to putting our belief in God into action in the world. And so often that looks like things like justice and compassion and generosity. And so Pilgrim is an open and affirming congregation of the United Church of Christ. And we are committed to supporting migrants and to and being healthy, and to putting our faith into action in a variety of ways. We have a number of efforts that are geared towards anti-racism and being a multicultural space. So without further ado, welcome. I bid you peace and grace on this special day. Thanks to our panelists for being here. And let's just give them an opening round of applause.
Thank you, Colin. And good morning to all of you. Thank you so much for coming. My name is Reverend Gloria Cox. I'm a long-term member of Pilgrim, and I will be moderating or helping to facilitate our discussion today. This morning's discussion is a kickoff event to a full day, actually a full weekend, of celebrating Black excellence, entrepreneurship, tradition, and spirit. And we hope that you will join us with those events that are beginning at 10 o'clock. You may have noticed there's a lot of activity in the building. We're setting up for the clinical services. We're setting up our vendor fair. We're going to be having a mac and cheese contest at 11 o'clock, so you'll want to stick around for that. But before we do that, we wanted to take a moment to step back, because given that this is Black History Month, it's also a time to reflect on our history as a community, to acknowledge and to be grateful for the progress that has been made, but also to take stock of the gaps in the equality issues that remain. One of those stubbornly persistent gaps is the topic that we're discussing today, the healthcare disparity gap between white and predominantly Black and brown neighborhoods in our community. And you wonder, can it really be an accident that there's a life expectancy gap of 16 years across communities that are only a few blocks apart? We'll begin our exploration of this question by hearing brief opening perspectives from our amazing panel, and I will introduce them to you in a moment. And when I do, you'll note that they are not only extraordinarily credentialed, but importantly, they have practical wisdom to share with us based on their own experiences and research. We will, after they do their opening discussion, we'll have a time of Q&A because I have some questions for them, but we really want this to be a community event, so we want to be able to hear from you. And to do that, a little public service announcement. If you have a question, I invite you to come forward to one of the mics. And as uncomfortable as it may be, I invite you to stand directly in front of the mic, lean into it, and speak clearly so that everybody can be part of the conversation. And then after we've done that for a bit, we'll take a break from asking the panel questions, and we want to give you an opportunity to reflect upon what you've heard, as well as your own personal experiences, with the goal of beginning to discern what is the so what. We know what the what, but oftentimes we don't think about the so what. And by that I mean, what is the impact of this situation on me as an individual, on us as a community, as us as leaders in the community? And therefore, what role should we or could we play in improving the situation? During that time, I'll ask you to simply just turn to someone near you and chat for 5 or 10 minutes about, again, what you've heard, just sort of your thoughts, give it a chance to digest, and then we'll reconvene as a large group, again, for people to have a chance to ask questions, and then we'll ask the panel to give some closing thoughts. So now, I'm privileged to introduce our panel, and they are quite august, so please bear with me as I share some information so you know who will be addressing you in a few moments. I'll begin with Dr. David Ansell. He is the Michael E. Kelly Presidential Professor of Internal Medicine and Senior Vice President, Associate Provost for Community Health Equity at Rush University Medical Center in Chicago. He is, do you want to know when you graduated? He's a graduate from a while ago of SUNY Upstate Medical College. He did his medical training at Cook County Hospital in Chicago, and he spent 13 years at Cook County as an attending physician and ultimately was appointed Chief of the Division of General Internal Medicine at Cook County Hospital. From 1995 to 2005, he was Chairman of Internal Medicine at Mount Sinai, Chicago. He was recruited to Rush University Medical Center as its inaugural Chief Medical Officer in 2005, a position he held until 2015. His research and advocacy has been focused on eliminating health equities. In 2011, he published a memoir of his times at Cook County Hospital, Life, Death, and Politics at Chicago's Public Hospital. His latest book is The Death Gap, How Inequality Kills, and was published in 2017. Dr. Carolyn Fitzpatrick currently serves as the Chief Medical Officer at West Suburban Medical Center in Oak Park. She graduated medical school from the University of Illinois at Chicago. She completed family medicine residency training at West Suburban Medical Center, and Dr. Fitzpatrick has an outpatient clinical practice at West Suburban's River Forest Medical Campus. Dr. Fitzpatrick enjoys giving back to the community. She's a volunteer board member of PCC Community Wellness Center, an active member of service-oriented organizations. She works diligently to promote leadership in children and improve the community at large in Chicago's west and northwest sides and near west suburbs. Heather Watson, LCSW, stands as a testament to the power of dedication, compassion, and relentless pursuit of social justice in the field of social work. With over a decade of experience, Heather's journey is not just a career, it's a calling. As the Director of Outpatient Services at Riveredge Hospital, Heather's leadership transcends the conventional boundaries of her role. She provides both clinical and operational oversight, ensuring her team not only meets but exceeds the standards of care they serve. Her academic journey is rooted in a profound understanding of societal structures and their impacts on individuals, beginning with a Bachelor of Arts in Sociology from the University of North Carolina at Charlotte. Further honing her expertise, Heather has pursued and obtained a Master of Social Work from the Loyola University Chicago, specializing in children and families and nonprofit management. This foundation laid the work for her unwavering commitment to Black and brown children and families in the Chicagoland area. Currently, as a PhD candidate in the School of Social Work at Loyola University, she is deepening her understanding and exploration of the systemic factors affecting mental health outcomes for marginalized youth. And Reverend Kirsten Peachey serves Advocate Health Midwest as Vice President for Faith Outreach, leading partnerships with faith community stakeholders and affiliated denominational sponsors. She contributes nationally to the field of faith and health and is known for convening and growing collaborative networks to solve for the root causes of health inequities. She's the founder for the Center of Faith and Community Health Transformation, a collaborative effort to work alongside faith communities to address the social conditions that impact community health. And she's also worked with partners to convene the Chicagoland Trauma-Informed Congregations Network to equip faith communities to respond to trauma and adversity in the community with restorative, healing-centered ministries. She is also a proud member of Pilgrim Congregational Church. And with that, I would like to turn it over to Dr. Ansell to share some remarks.
Good morning, everyone. I know she didn't want to give the dates when I went to medical school, but the last time I was here was when Pilgrim was opened. You know, I was in a little basket. And I know what you're thinking, he's aged quite well. Now, thank you for having me today. I was told I have 5 minutes, and that's like just a warm-up. But no, I'm not going to take. I think you know, I loved your words. Thank you so much. But you said, so what? And I say, now what? I think. So this morning I thought, when I got invited, because I didn't read it very closely, that I was going to New Mount Pilgrim Church in Garfield Park, because that's the church where I've been spending most of my time when I'm not at Oak Park Temple, member here. And I just wanted to take you back to a table back in 2017 when a group of hospitals got together with community members at Malcolm X College, and we had this idea, and we showed a map. And I'm sitting at a table at the back, and with the pastor, Marshall Hatch, Sr., and some community members from West Garfield Park. It was just an accident that I'm sitting there, because I could have sat at another table, but here I am with Pastor Hatch. And the map was the map that we had put together for our community health needs assessment at Rush back in 2016. And it went like this, that if you live in the Loop, you can think also Oak Park, but think about this, you could live to be 85 years old, and if that were a country, it'd be ranked first in the world. Think Japan or Monaco. But if you went 7 stops down the blue line to Garfield Park, West Garfield Park, Pulaski and Madison, 2 miles from here, life expectancy at that time plummeted to under 69, 16-year life expectancy gap. And post-COVID, that life expectancy in Garfield Park now is 66, 67 years. So I wanted to put that in perspective. If you live in the Loop or Oak Park, it's like living on the Upper East Side of New York in terms of life expectancy. See, the gap is not in health, the gap is in living conditions. But if you live in West Garfield Park, the life expectancy, if it were a county, it'd be the lowest life expectancy county in the country. Think Pine Ridge Sioux Nation, 2 miles from here. And think about what the needs are of Pine Ridge Sioux Nation. I was just having a discussion with someone that, I'm going to get into the actions now, but about that there's going to be one of the actions we've taken is the hospital's going to do is build a laundry linen on the west side of Chicago that's going to ultimately hire 200 people. And I was told by another a leader of another institution that's no longer on the west side, well, we're not there anymore, meaning we don't have laundry to give to this facility. But that idea that we're no longer here anymore is true for all of us. We no longer go there. Pastor Hatch, when he saw the life expectancy, said the Bible says, this Matthew something, someone can quote it, I'm Jewish, so that's the new book. I'm of the old book, but they said that the Bible says the last shall be first. And that really struck me as a leader at Rush, as a leader on the west side. Rush has been there 185 years, 3 days before the city of Chicago was inaugurated. So you can't look at the conditions on the west side and say to yourself, that's not my responsibility, or that's not my accountability. And so we as an organization, we're an honor roll hospital, there are 20 of them in the country, decided to make the elimination of the life expectancy gap central. So now what? Now what? And that if we just did business as usual of providing care for patients, excellent care for patients, at Oak Park Hospital in downtown and in Copley, that wouldn't be enough. And so we decided that we needed to eliminate the death gap. First we said we want to cut it in half. And the community said to us, are you kidding me? You're telling me that my children only have half the chance to live to the age of 65? And so we've made elimination of life expectancy gap. Through that table that day, something is rising in Garfield Park, and I ask all of you to join this. So imagine what happens, just for a second, when a community, so we know what happened in history, right? There was slavery, there was a little bit of Reconstruction, there was Jim Crow, we've had mass incarceration. But the biggest thing that's keep the death gap from persisting is the fact that if you live in Oak Park, you shop in Oak Park and you drop your money in Oak Park, and you hardly ever go to Austin. You never cross Austin Boulevard. And people in Austin come here, and the money comes here and it doesn't go there. So we're in Garfield Park. We won the Chicago Prize, a big capital prize, for something called the Sankofa Wellness Village. And it's the first capital investment in that neighborhood since Martin Luther King was assassinated, and the neighborhood went up in flames in 1968. A health center, a YMCA, the building is going to be owned by the community. The revenue from that building is going to go to local businesses. There's going to be an arts center that's open already. There's an economic development center. There's a community grocer initiative, because when the Aldi's left town under the cover of night, we had a demonstration. So now what? Show up in Garfield Park. There's a lot of work to do. First thing you do is take this congregation one Sunday to New Mount Pilgrim, but there's a lot of work to do, and be really great to have the Oak Park support this effort. We have this community rec center. People know about that down on Madison. I was one of the co-leads for it. I'm one of the co-leads in Garfield Park. And it's really interesting. On Madison Street, 2 similar buildings. But join us. Now's the time. Thank you so much.
Well, good morning, everyone. And I'll take much less time today. I'm a woman of few words, but just wanted to share with you some thoughts today. So I actually grew up in the Oak Park community and attended Oak Park River Forest High School, right across the street from us. And even though being in this community, I grew up, my parents were divorced when I was about 9 years old. So most of my time growing up, I lived in a household headed by a single mother. And along the course of the way, you start to become more aware of your surroundings, of the continuum. And so I think when I was in high school, started to realize even more that there were those who had much more and those who had much less. And those who had much less, I could at times see sometimes the pain, the anger, the frustration of the things at that time, you know, as a teenager, as a high school student that are important to you, you know, whether that might be the latest, you know, at that time, the designer blue jeans, that sort of thing. But you could see it in the faces of the children, the students there, that even though we all were in the same place, that there were differences in the things that we experienced, differences in the things that we were all able to get from the same school. But no matter where children are born, no matter what school you go to, all children deserve the ability to have access to excellent health care, education, healthy food, all of the things that we know that set people up for success in the future. And from very early ages, there are children that are being excluded from the so-called American dream. And we do have to ask ourselves why, and how can we contribute to making sure that children have the experiences that they need to grow up to be healthy adults, to be able to contribute the things toward our society. Because if we don't, we'll miss out on the gifts that they have to offer to all of us. I work at West Suburban Hospital, and West Suburban, which is located in Oak Park, but uniquely situated on the edge, the borderline of two communities. One side being the Oak Park community, and the other side being the Austin community. And we take care of the vast, diverse community around us, but know there are different needs that people, patients from the communities, you know, what their needs are. And we are dedicated to providing, you know, what both of the communities need. We really have to highlight when we're talking about healthcare disparity, about maternal health. There's a maternal care gap. And in this community, actually West Suburban is one of the only hospitals that moms can still deliver babies at within a 5+ mile radius. We know that healthcare outcomes for maternal patients improve when you have care that's close to home. But even in this community, you have to travel, you know, far places. You know, sometimes there's traffic on the Eisenhower, and we have heard of people who have babies in their car because they can't get to where they're, you know, planning to deliver. So we do have to address that. We do have to address the fact that regardless of socioeconomic status, that our Black and brown mothers are, they have higher rates of complications and death through pregnancy. And I know that there have been lots of initiatives to try and address this, but we really need to also, again, us in the healthcare community, need to look at ourselves and how are we also at times contributing to this? How at times are we not paying attention to the signs and symptoms that our Black and brown mothers are telling us? And because they don't use the words that are in the textbooks, we don't realize that they are actually having a pregnancy complication that could be life-threatening. So we do have the ability to do better, to look at ourselves, to think about those implicit biases that we all have, and challenging them, recognizing them is the first step, and then making sure that we do something to counteract them. It's really important that all of us in this community, the faith-based community, all of our different healthcare communities, that we work together, that we collaborate, because that's the way that we're really going to be able to overcome some of the healthcare issues and close the gap. And out of that awareness, we can highlight not only just improved outcomes for healthcare, but also reaching back to our youth and making sure that we also let them know about opportunities in healthcare. There are all sorts of opportunities at many different levels that students could potentially work in healthcare, because we need to have a diverse healthcare force so that there are people who are representative of the patients that need to be cared for. When people feel comfortable, when they get to know their providers and are able to relate to the providers that they see, we know that there are better health outcomes. So we need to focus on also creating a pool of healthcare professionals in order to care for our community. Thank you.
Good morning. Thank you for that beautiful introduction. Okay, so again, my name is Heather Watson. I am a licensed clinical social worker, and I want to start by saying that mental health is health. I know that I am up here with some brilliant practitioners from the healthcare field, but I want to offer a perspective from mental health. I also want to say that access is key. We talk about access from the healthcare perspective, but we don't necessarily talk about community resources for mental health. And I too am a woman of few words, so I will leave you all with this. Access, access, access. Once we can figure out how we can access these limited resources, we can collaborate to make our communities better. Thank you.
Good morning, everyone. So I'm going to be speaking today from the perspective of a theologian, as well as a social worker, as well as someone who's sort of been immersed in public health for many years. So really trying to bring together a number of different streams. And I'm kind of old school, and I like images and graphics and things like that. So I have this handout that's there on your pews. And I'm going to just kind of use this as the guide for our conversation right now. So I want to start just this pyramid is something that comes out of public health. This is used a lot in public health to kind of indicate where we need to be working to have the greatest impact on health across whole communities. And so I'm going to talk a little bit more about that period in a minute, but I've added some things to it, again, as a theologian and as a social worker. So the first thing I've added are these quotes at the top. The one from Martin Luther King Jr., "We are caught in an inescapable network of mutuality, tied in a single garment of destiny," which sounds really lovely, and I'm sure we all agree with that. But that's where this idea then on the right-hand side where Wendell Berry's quote says, "Community is the smallest unit of health." So Dr. King's vision of us being really all interconnected in this inescapable network of mutuality shows up in this idea of community as the smallest unit of health. And the whole idea that Wendell Berry talks about is that health is membership. Health is how we are members together in the world. So he says, "I believe that the community, in the fullest sense, a place and all its creatures." So community, not just us in our human relationships with each other, but the place and all of the creatures and all of the flora that's there, is the smallest unit of health, and that to speak of the health of an isolated individual is a contradiction in terms. And so that really challenges us to think about health in a different way, because mostly we think about me and my health and my body. We think of, sometimes if we think we're being holistic, we say mind, body, spirit. But really what we're talking about is my mind, my body, my spirit. And is there any way, if we are in an inescapable web of mutuality, that we can really have a body that's distinct from other people's bodies? And so it's a challenging idea and something that really shifts the way that we think about health and what our role is, what the now what is, when we think about how we're called to address this issue of health inequity, which is really about how some parts of that body, how some parts of that web get privileged over others. And that happens in many, many ways, and we would have to spend more than 5 minutes per speaker talking about those things. And one of the ways is access, of course. One of the ways is economic investment and so forth. So when we think about the now what and what we want to do about it, a lot of times we spend time at the top of this pyramid. So we think if we know better, we'll do better. Has anybody ever said that or heard that? If we know better, we'll do better. And that is true. If we know better, we'll do better. But really when we think about what's going to change that 16-year life gap, education is really not going to get us there. But that's where we like to spend a lot of our time. And as someone who works for a healthcare system, we spend a ton of time educating. And I do it in my own program too. We do a lot of education. Clinical interventions, treatments for high blood pressure or high cholesterol or diabetes, those kinds of points of care. Farther down, something that will get us a little bit farther are these long-lasting protective interventions, so immunizations, smoking cessation programs, testing and screening and so forth. Getting a little bit farther is changing the context. I was part of some of the public health efforts in the city of Chicago to raise the tax on cigarettes. And my public health colleagues were so proud of the fact that Chicago has one of the highest rates of tax on cigarettes in the country, because that changes behavior. That changing the context, making cigarettes so expensive, makes it so people don't smoke as much. And then the bottom level there on the pyramid as it usually appears is the socioeconomic factors, and that's where Dr. Ansell was talking about, where do we spend our money? Where do we invest? Where are the housing gaps? Where are the education gaps? All of those kinds of things. The disinvestment in communities, intentional disinvestment, all of those kinds of things. Even things like trees, for example. Our child, when we would come into Oak Park, I live in Oak Park, we would drive into Oak Park from the west side, from the time that they were, 6, would know that we had crossed into Oak Park. Why? Because there were trees. All of a sudden, it was a totally different environment. And so trees actually are a great indicator of the health of a community, the violence rates in community, the economic status of a community. Trees are a huge factor. So that's just another example of these sort of like all these social kinds of things that impact, have the largest impact on health outcomes. And we spend as healthcare providers, we spend virtually no time there. Now, Rush and Dr. Ansell's work is really starting to change some of that, and other healthcare systems, including Advocate Healthcare, are really starting to think about, okay, well, how do we invest in housing? How do we invest in making sure that communities have what they need and are being treated justly? But we have a lot of work in front of us. Dr. Fitzpatrick talked about the maternal health outcomes. One of the so-called canaries in the mine for health equity is infant mortality rates. And again, just to kind of give you an idea, in Oak Park, our infant mortality rate, and this is deaths per thousand, so this is a rate, this is not a number, this is not the number of babies who die in Oak Park, this is the rate, is 3.8. The US rate overall is about 5.4 deaths per thousand. In Austin, the rate is 9.5. If you go a little bit farther west into some of our West Suburban neighborhoods, Bellwood is 17.5. Now, are the women in Austin so different from the women in Oak Park? The families in Austin, are they so different from the families in Oak Park or from Maywood? No, it's the social environment and the impact, I will say, also of racism on people's bodies, that racism gets into people's bodies, the effects of racism, and there's a lot of research and really important work in that space. So these are not easy issues, and so I invite you also to think about the very bottom bar that I've added, that is the theological piece that says, we need socioeconomic factors to change, but really kind of at the root of all of that is this idea of how do we create loving communities of justice, hope, and wholeness. Loving communities where we love each other in this network that drives us to be engaged with each other and to actually take that now what action. And that the way that we do that is in the green arrow down there at the bottom. Again, we'll do another one maybe on some of these ideas, but this idea of hopeful imagination, spirit, power, and love, which are our gifts, particularly of faith communities, but also of people who really care and really are driven out of a deep concern. And so the hard work, the hard now what, has to be something that we live and integrate into our faith community life. We have to be fed by our faith communities and by our spiritual lives to do this work, because it's long term and it means disruption and disrupting the way that we think about health, the way we think about each other, the way we think about our connections to our communities. Thank you.
Okay. It's on? Okay. Thank you all. That gave me so many things to think about. And the mortality rate thing is really disturbing, and I hadn't thought about like people going into healthcare. But this is the time for other people to ask questions. So if it gave you some things to think about, I invite you to come forward to one of the microphones and pose a question to anyone on the panel or in general. And we can take a few moments as you gather your thoughts, and hopefully we'll come forward and share. I had one starting question, because we started, when we were preparing for the panel, as we were gathering, a lot of us talked about what a special place Oak Park is, and that it's sort of an intentional community, and a lot of people move to Oak Park for specific reasons. What is the cost to us as a community when these things exist? I mean, there's like, we should care, but we're also, in the United States, we're a little bit about like, yeah, I care a lot, but why should I do something? Kind of what's the impact to me if I don't do something? So this gap has been persistent. If we don't narrow it or close it, what's the bad thing? What's the impact on us who don't live in those communities? Any one of you can talk about that. And there's a microphone there that you guys can use. I've read your bios. None of you are shy. Oh, I think.
Well, I can maybe address part of that question. And, being a member of the Oak Park community, both growing up and also, raising our family in the Oak Park community, I think that if we don't do anything to change, things will become even worse. And I feel that a lot of us in the Oak Park community and other surrounding communities as well, we do want to see our communities thrive. We do believe in the principles of having diverse communities. We want to, continue that existence. And, when we do nothing, when we are silent, we know that silence kills. And we also know that faith is not something that is stagnant. Faith requires action. That is our calling, to be active in the things that we know are important. Lean on our faith in order to become more active, to make a difference in those around us.
I love Dr. Fitzpatrick. I just to say something, just for my own thought, as a white person who came to Chicago to train, because I knew something was wrong, but I couldn't quite put my finger on it at the time. And as you noted, I'm very old.
I didn't say that.
I know she did. But I just want to sort of talk to you about sort of my experience to answer your question. So my parents emigrated to this country, and their whole families were wiped out in Europe in the Holocaust. And as a young boy growing up, it was hard to sort of wrap your head around sort of what happened, like all but 3 relatives, And when I understood what the people had gone through there, it was racism, mass incarceration, and genocide, and yet in this country, I was assigned a different place. I remember watching, 1965, that takes you back, the first movie that was ever played on American TV, 50 million people were watching, Judgment at Nuremberg. It wasn't about the Holocaust, about the trial of the people. So I don't think they were ready yet to show, what really happened. So it was a secondary thing about that. In the middle of this broadcast, Frank Reynolds, ABC News, comes on and says, "We interrupt this broadcast to bring you Bloody Sunday, Selma, the Edmund Pettus Bridge." The juxtaposition of those 2 things really woke me up. Just saying that you couldn't make this stuff up. And then I knew something was wrong. I came to Chicago to Cook County Hospital. But it was actually, and then I went county to Sinai, but I drove, I moved to Oak Park after about 7 years, drove every day across the west side. What you noticed, what's happened. So I began to understand, and in the bodies of my patients as well, how the diseases that I was seeing, and the inability to really treat them with what we had been taught in medical school, it came to me that there was something else going on that no one was talking about. And as a white man, I had to acknowledge racism. And to acknowledge that racism, in fact, when I got in front of the board and talked about the life expectancy gap, I said the root causes, among the root causes, these were my very words, were structural racism and economic deprivation, not poverty, which is an outcome, economic deprivation, which was a cause. And the causation of the structural racism. So we look at these neighborhoods of concentrated disadvantage, as the sociologists calls it. And obviously, Oak Park's a healthy community, in an intentional community, but not necessarily, we didn't eliminate racism in Oak Park, right? But intentionality around it. But no one thinks about the neighborhoods of concentrated advantage. So think about this for a second. Growing up in a neighborhood like Oak Park and watching my kids go to OPRF and the whole thing. Oak Park's a neighborhood of concentrated advantage. And it's largely, with River Forest and Berwyn, and with the exception of Austin, surrounded on each side by other neighborhoods of advantage. Same with Glen Ellen, same with Downers Grove. And when you're in a neighborhood of advantage and you're surrounded by other neighborhoods of advantage, as a child, even if you're disadvantaged, you have more opportunity. You're going to bump into someone. Someone's going to take you under their wing. But imagine what it's like to grow up as a child. I began to do this process of a neighborhood of concentrated disadvantage. First of all, we don't go into those neighborhoods, right? Who goes into those neighborhoods? There's people from other neighborhoods of concentrated disadvantage. So as a neighborhood like West Garfield Park, or even Austin has Oak Park on one side, but otherwise, West Garfield Park surrounded on all sides by their neighborhoods of concentrated disadvantage. And it's only people who go in and out of those neighborhoods or people from other neighborhoods of concentrated disadvantage. And that correlates 100%. Straight line correlation with infant mortality, homicide, overdose, heart disease, you name it. And it's deliberate public policy, and that's the thing that we began to think about changing. So the only way we're going to change this is through concentrated investment. But for me as a white man, as a leader, I was a leader at county, I was a leader at Mount Sinai, a leader at Rush, why hadn't I spoken about racism earlier?
Do tell.
That's a good question.
Yes.
Particularly given my family history.
Yeah.
Right? So I had to do a root cause analysis. Like I did a root cause analysis on why are people dying in Garfield Park earlier, Austin, earlier than Oak Park, and I got to, among the causes, structural race and economic deprivation. I had to do root cause analysis on myself. Why is a doctor whose family went through this, came to this country, goes to Cook County Hospital, why did it take me so long to speak about it? So you ask why 5 times. Well, why? Well, speaking about it, I wasn't comfortable speaking about it. Well, why weren't you comfortable speaking about it? Well, the people around me weren't that comfortable speaking about it. Well, why weren't they comfortable speaking about it? Well, it's kind of impolite to talk about it in group. Well, why was it impolite? And at the end of those 5 whys you get, because everyone in the room was white. And I never noticed. So now I notice. And I think this, so if we don't do the work of personal change to interrogate how we've all been indoctrinated. You mentioned something that was very powerful. Turns out that the Commonwealth Fund has reported over and over and over again, that's why we don't need reports, we need action, that 1 out of 4 Black people, 1 out of 4 Latino people in the United States, these are older people now, like old people get a little bit of a break. When they go to it, they say, in the last year I've experienced a discriminatory, I had a discriminatory experience in healthcare. And we said, we have to build trust. Well, actually, we have to break down mistrust. Imagine you're going into a patient's room and there's someone in there who's likely in the last year had a 25% chance of having an awful experience. How do you enter that room? Most white doctors are never thinking about that when they walk around. And I can say for the women in the room, right, how many times have you been minimized, negated, ignored, okay, because of your gender, right? You experience it all the time. So the point is, long-winded way to answer the question, if we don't interrogate ourselves, and the movie, the current of racism that's playing in all of our heads, we're never going to get to the kind of actions that are going to make a difference. Because when we're seeing the patients, they've already been hurt and harmed. So when we get to that, when they come to us, even if we're empathetic and kind and doing that, the harm has been done already. And that's why I quit being a chief medical officer, and it's why I began to speak about racism, but also not just speak about it, do something about it. We're hoping like this capital without capital, without wealth, you can't have health. And the opportunity for us as a community here is, how do we build Austin? How do we go to Austin and shop? You know, they're building that corridor across Chicago Avenue. How do we go to MacArthur's? We have to start individually. Go spend money in Austin and Garfield, but you can do that individually. Just go buy something. But as a community, we need to really think about what's our obligation and accountability to take Austin, to help Austin economically.
Thank you for that. So I want to piggyback off of something you just said about the 1 in 4. So I think that also goes back to access, and I want to share this stat with you all. So nationally, 4% of psychologists, 2% of psychiatrists, 22% of social workers, and 7% of marriage and family counselors, 11% of professional counselors are reported to be Black. Okay, so if we're talking about access and we're talking about wanting to help individuals that might look like myself, we have to have access to educational attainment, right? We have to have access to the educational perspective, the component. We have to access these resources to be able to help individuals that look like us or look like myself. And with that being said, it's also awareness. If we're not aware that we're experiencing anxiety, depression, we're not gonna know to go for support or go for help. Thank you.
Did you have anything you wanted to add on that?
Just the only thing I'll just add is, you know, your question sort of also, it's kind of part of that disbelief that it actually is functioning, that, you know, that we are interconnected. You know, it sort of wonders, well, how does it matter if somebody in Austin dies 16 years earlier than I do? Does that really have, you know, how does that? But, you know, just imagine a thriving Austin, all of the possibility that's there that we're missing now because of the disinvestment, because of the, what's the word you use, Dr. Ansell?
Capital extraction.
The capital extraction. Higher costs for insurance, because we're not making sure that people have access, that people have that the environments are healthy for people, et cetera. So anyway, that's probably enough, because I know it looks like there's a question.
Well, does anyone oh, yes, I'm sorry. I was like, turn this way. I apologize.
This is a fascinating conversation. Thank you all so much. I love the idea of the loving community and also the personal change that's required. I'm curious, how do you get an institution like Dr. Ansell, like the healthcare institution, to own the larger context question? Because health institutions have sort of become disease management focused. So how do you get that ownership to actually happen?
That's a great question. I think loving community is at the center of all of this. So I want to just acknowledge that. And, you know, I have to say, doing this work, which I never thought when I went into medicine I'd be into doing community development, I've entered into an amazing, loving community. And it's been, I want to say, a spiritually moving experience for me to be an old man now, older, but feeling the energy that I have because of the amazing love that's in a neighborhood like Garfield Park and such. I just want to acknowledge that your idea, what is the root of this or what is the solution, is loving communities, because I do think that's that, and loving communities have the opportunity to be healthy communities, but only if you feed them, right, and with them. So when I looked at this, so I was chief medical, so imagine my career, right? I come to Chicago because I knew something was wrong. I go to Cook County Hospital. I was like, oh my God, it really is wrong. It was the intersection of everything that was right and wrong in healthcare. In 17 years, I never had to bill a patient. But there were things that were across the street at Rush that were literally out of reach for me. Then I went to Sinai for 10 years, and I'm chair of medicine. I want to give you an example of of how we got the hospitals together. But first I had to rearrange my brain. Because I thought if doctors like me and Dr. Fitzpatrick just showed up at West Suburban or at Cook County or Sinai or anywhere, that would be enough. And it was very clear to me early on that wasn't going to be enough. Let me give you a very distinct example of how the inequality in healthcare and the way that things are aligned. So, for example, a hospital in a poor neighborhood or a hospital that is designated to take care of a poor or historically excluded population will likely be a poor hospital. And that's just a fact, right? And of course, in this country, because things are layered by race, with white on top and black and brown on the bottom, there'll likely be a hospital that will almost exclusively, not 100%, serve people, you either serve people of color or you're going to serve white people. U.S. News and World Report hospitals, there are only 3 hospitals that are racially inclusive of the 20. 3. Cleveland Clinic, WashU, and Rush. The rest of them are racially exclusive. So there's a fact you wouldn't even think about. So I'm at Mount Sinai. A white person would get admitted to Mount Sinai if their car crashed in front of Mount Sinai. I know it sounds, but it's true. And so therefore you get different levels of healthcare. I was the chief medical officer at Rush, and suddenly it was like my patients and I had landed on a different planet, because they had come with me from county to Sinai to Rush. I still have some from my internship, not many. But we did a litmus test on the healthcare system. It's really screwed up. It's unequal. We train the exact same way, but the conditions under which we practice, what resources are available for us, literally across the street you can get different care. 0 of my patients in 30 years, county in Sinai, ever got a life-saving organ transplant. 0. And none of the patients of any of my colleagues ever got a life-saving it wasn't an option. We never even thought about it as being an option. And yet, I got to Rush, and suddenly organ transplantation is available. So people gave, but they never got, because the organs came from the black and brown patients in the ICUs of County and Sinai and went to the transplant centers. It was unidirectional. So the fact is that something was hugely wrong became obvious to many of us practicing in these settings. So the solution was not more health care. I mean, that became clear, and it wasn't just us showing up, that the solutions, yes, we need to show up, that we have to relieve human suffering, that's our job, but it wasn't going to solve this problem. So this meeting at Malcolm X College in 2017 was to get a bunch of we didn't feel like we had any credibility. Rush? Are you kidding me? You know, we used to call it the evil empire when I was at Sinai. But so this was new for us. And we got the other hospitals and the health department and just asked the question of the community, what if the hospitals and the community could partner together? What would it look like? And we did listening tours. How about that? Listen. My wife says that all the time. How about that? Just listen. And so what did people want? They did not want more health care. They wanted jobs that pay well. They wanted support for local businesses. Mental health. Mental health. This is 2016. We need help. We need help. Our children are feeling hopeless. Our children need help. That's what we heard, and we created an organization called Westside United. 6 hospital systems, community board with community voice, because at the end of the day, it's power, and who has the power and who has the decision, with the idea of what would it look like if we all partnered together to make the West Side better. And it's led to things like the Sankofa Wellness Village. You can look it up. It's leading to a laundry linen on the West Side that's going to hire 200 people because the hospitals can send their laundry there. It's leading to really thinking about partnership with community in a very, very different way. But we need the kind of capital investments. Oh, capital's been extracted from these neighborhoods. You need the kind of capital that went in, like the Marshall Plan after World War II. Germany wanted to, that did other. We revitalized Germany, but we intentionally did not invest in these neighborhoods, and we just need the kind of capital investment that allows everybody to rise. That was my understanding as a doctor, that no amount of more medical care was going to solve the problem of structural inequities based on racism and other things, and we needed these capital investments, and that's what Westside United has been trying to do, and we're beginning to see it. It's just not at the scale that it needs to be yet.
We have another question.
Good morning. Thank you, guys. My question is kind of related to the statistic I believe that you mentioned earlier. How do we develop partnerships related to healthcare organizations so that we can get to, I'm in the insurance business, so it's a somewhat selfish question, but how do we get to these development of partnerships so that we can develop ways in which different communities can have the same access to healthcare and then, i.e. better insurance? So my office is it's kind of in between Oak Park and Austin. And so sometimes if I look at 2 different zip codes or 2 different streets, or 2 different parts of the same street, there's a gap. And so how do we develop those partnerships proactively so that we can then start to see, if I live on one end of Madison, I get the same as I get the other end of Madison, as an example, and anybody can answer the question.
So I think for me that, again, goes back to education. I think if we look at some of the surrounding undergraduate and graduate programs that are here within the Chicagoland area, just kind of partnering with them so that you can create internships, create just programs in general to support the community.
I don't know how this response is going to be received, but I have to say that my husband also works in the insurance industry. And I think we have to take a step back, ask ourselves, why has the insurance industry created these ways of charging different rates? I know that they have the calculations that based on what events might occur at certain zip codes, certain streets, what have you. But when you really take a step back and think about it, the racism is built into the calculation. We in medicine have to ask ourselves the same thing. A lot of us were taught race-based medicine, and we accepted it as fact because that's what we were taught in medical school, until people started to challenge the calculations that determined if someone has end-stage renal disease, if they qualify for a kidney transplant. The calculations have racism built into them so that less of our Black and brown people qualify to get an organ transplant. Those are the things that we have to start opening our eyes to. Those are the things that we have to start challenging ourselves to. The people who can not afford the premiums for the insurance policies are being charged more, and that's a problem.
Yeah, so I would just have one thing to say, which is universal health care. You know, I mean, that's, I don't know if I need to say anything more than that, but yeah. And then just the other, to Jenny's question, maybe she's not, oh, there she is. The other thing I would say very, very simply is also federal regulation. How can healthcare systems start to make the shift? Healthcare systems are starting to make the shift because federal regulations now require not-for-profit healthcare organizations to show what are you doing for the community that's actually going to benefit the community. And since that regulation has been in place, I've noticed, you know, I've worked for Advocate Healthcare for 30 years, I've noticed a huge shift in our awareness. Oh yes, our patients are actually people that come from the community, and the conditions in the community are affecting the well-being and frankly, also our bottom line. And so we need to do something different. And so there has been, I would say, over the last 10 years, a huge movement among healthcare organizations to really take on health equity, to understand the social drivers of health, and to begin investing there. There's still so much more that could be done in so many ways that healthcare systems could really be, you know, proactive about this. There's now a national organization or national network called for anchor institutions, you know, because a lot of times healthcare systems are economic drivers within the community, or could be. So sometimes it takes that external push to say you need to be accountable for what you're doing.
If I might just add to the insurance question, just like the trees, right? You know you're in Oak Park when you see the trees. When there's a lack of trees, you can actually tell what the life expectancy is by the correlation with the trees, or you know, you can drive through and you can probably make a guess. But there's a book to read if you have never read it. It's called The Color of Law by Richard Rothstein. And Richard Rothstein won the, I don't know what National Book Award or the Pulitzer Prize for this a couple years ago. There's one thing about, there's so much of this that's designed in, which is Dr. Fitzpatrick was saying, in the design of this inn. So while we did pass some laws in this country, they fell very, very short. I like to talk about, so we're redlining. Oh yeah, that happened a long time again. But there's redlining by insurance. I want to tell you a story, just a little bit. So in the book, The Death Gap, I talk about this patient of mine, been with me since county, still alive. And the worst thing that could ever happen to her, she said, would be if she had a stroke where she couldn't talk. And that's exactly what happened to her. She followed me from county to Sinai to Rush, and she's having a stroke in the office. And the last word she said, I went into her, was she's having the stroke right in front of me, and said, "Who dropped you off at the hospital?" And her boyfriend was named Daryl. And she said, "Dr. Ansell." Those were her last words. But I tell the story about how hard it was to treat her hypertension and diabetes. And she worked in the school district, she had a job, but she had to pay her insurance on her house and other things, so she wouldn't buy her medicines. So against the rules of ethics, I oftentimes gave her money. As a doctor, she's supposed to be giving me the money. I'm giving her money so she could buy medicines. So I tell that story in The Death Gap. 2 weeks ago in my office, her daughter comes in. I've been the family's doctor, generations now. And her daughter comes in. She's about 50 now, her daughter, and her blood pressure's through the roof. Her diabetes is out of control. She shows me the insurance bill on her house in Humboldt Park. The insurance, and she has a house in a coach out, $16,000. And she's in tears. And the reason why she's not taking her medicine is she's putting money to trying to pay off the insurance. Her mother lives in the house, doesn't know about it. And so this stuff is built in, designed in. Do you know what I mean? And you know, so it was Citibank, and the next week I'm in Lawndale with a class from Rush, and there's Citibank on a visit from their philanthropic end to give money for some project. And I'm thinking the discrepancy between these two. These things are designed in, just like the medical calculators. They're designed in how appraisals are done, who does appraisals, what a house is worth. These things are replicating, designed in, and the best agent and the best doctor can't buck the system. So I think we have to really, this is about law. I recommend you read that book And we've got to change the laws because right now the laws are perpetuating the historic racism. Even if people are not intentionally racist, the day-to-day life is. And no amount of goodwill of institutions, being an anchor institution, or the goodwill of doctors is going to overcome this. It's still with us. And it has devastating effects on, it's a matter of literally life and death. And I can see it in this patient, generationally. You know, the same thing happened to the mother is happening to the daughter and will likely happen to the granddaughter.
Oh, one thing, I think, were you, yeah, I'm sorry.
The points were touched upon. Hi, hello, my name is Sam, also in healthcare, Dr. Fitzpatrick, good to see you again. The point I wanted to make that you've made it, I think, sort of around is the economic factors. So what we've seen in the last year, the reduction of Medicare reimbursements to healthcare, the reduction of Medicaid reimbursements to still the very few healthcare facilities that accept Medicaid. You know, we're seeing it collectively all around. That access is really at the root of a lot of this. Obviously, there's a number of different factors: food, economics, transportation, et cetera, all interrelate. But if people do not have the accessibility to actually seek health care, the calculus doesn't change. We're going around in a circle, you know, continually, and it's actually getting worse. If we look at Russia's system, Northwestern system, U of I, the predominant, a large number of the specialty groups within those facilities are leaving those facilities for economic reasons and creating, you know, sort of separate organizational structures. You know, the time the patients have to wait to see a healthcare provider continues to expand and expand. You know, we have patients waiting months to see oncologists, to see orthopedic surgeons for consults. And it is insurance discrimination, because I can tell you for a fact that a lot of those hospital administrators are geared, who's got Blue Cross Blue Shield, who has Aetna, who has United Healthcare, who has Medicaid. And that goes into the calculus of accessibility. And so, you know, I looked for you guys for the discussion of solutions at your level, and being those medical providers that have been in there. There's the governmental structure that's set up against us and is continuing to do that. You know, and Dr. Fitzpatrick, the reason we had the stakeholder meeting at West Sub last year and bringing that collective group together was to try to make the changes at the municipal level, because we thought that they are more accessible. They are our neighbors, they live with us, and getting them on board. And typically, they separated and segregated themselves and left it up to the state and the federal government. And we looked at it and trying a different tact, and we'll continue to do that, working with our municipal government leaders to make healthcare changes at a local level, hopefully to affect that next level going forward. So I would love your opinion and things that you guys can talk about. How do we change that next level of the structure to really address what we see as sort of the root cause of healthcare in these underserved communities?
Yeah, no, thank you very much for that. And I do think that we have to look at how our healthcare systems, healthcare providers are receiving their compensations, because the way that things are kind of laid out, it does limit access. We're very grateful for the Affordable Care Act, which did increase the availability of medical insurance for a lot of people who never had insurance before. There was a lot of people who were able to enter into the healthcare system to get care. And in Cook County, we have county care where there is increased coverage for patients. But we have to realize that some of those insurances only cover certain things. And our communities have a lot of needs. We have very sick patients who have these insurances, and some of the things that they need are not covered. Specialty care is still very limited to people who are underinsured. And if they need to see a specialist, thank goodness that Rush takes county care insurance, able to, you know, send patients who might need specialty care that way. but there still is a lot of limitation, and yes, the waiting periods are very long. And, you know, speaking of the old days of Cook County, you know, a lot of us do remember, you know, you basically, well, you need to see a specialist, you go there at 7 o'clock in the morning or whatever, and you sit there and you wait all day with hundreds of other people sometimes, waiting to get 5 minutes of somebody's time and hope that they can address your concern. And, you know, thinking about, well, there are people, yes, a lot of us maybe think of people who are underinsured or have no insurance, is that they don't have a life, they don't work, but there's a lot of working poor out there. And so they can't afford to be able to sit in a room with 100 people at 7 o'clock in the morning, hoping that they can see a specialist, and then they miss work, the job that they do have. So it's a choice. You have to make that choice between, do I want to receive my health care, or do I want to, you know, be able to go to work to get the income that I need? These are decisions that people are making every day. We need to, you know, come up with, we have better solutions now, but we need to continue to push ourselves to provide access, especially access to specialty care. Very grateful, thankful for healthcare organizations, federally qualified health systems that are trying to address some of those needs, but we still need more.
You mentioned single-payer healthcare. So I have a talk I give, the margin or the marginalized. So a friend of mine is a very famous doctor in the United States, Don Berwick, who ran Medicare and the Institute for Healthcare Improvement, wrote an article called Salve Lucrum. It was found in Pompeii, under 15 feet of ash, and it means hail prophet. So you raise something that's really important. So we live in a capitalist society. Capitalism is the religion of the world. But when you allow capitalism to run amok across you know, our care, our foundational care, whether it be education or it be healthcare, you're always going to end up with outcomes that are going to favor those who have more over those who need more. And while the Affordable Care Act, I wrote about in the death gap, I called it a pig in lipstick. While the Affordable Care Act did something really good, it also perpetuated a system of care that has the wealthy on top and the poor on the bottom, that has white on top, or those who've been assigned to white, and black and brown on the bottom. Is designed in just as we designed into how we did kidney function. And this is a national problem, and it's not just for poor people and people of color, it's a problem for the middle class. The average premium for a family of 4 is $25,000. The average copay and deductible for an individual is about $6,500 a year. This is going to be is a continued political issue because we didn't solve it right. And it's not going to happen this election cycle, but I think the next election cycle, the healthcare in America is going to rise to the top of being an unsustainable economic model for everybody. And so the hospitals are, 80% of hospitals lost money after COVID. In the United States now it's about 65%. The bond agencies, the banks have said it's an unstable, industry. So something's got to give here. And if you say, well, gosh, this whole thing doesn't work, look at the COVID mortality in the United States. 1.5 million people died in the United States. And had we been Costa Rica, it would have been 500,000. And had we been Australia, 900,000 more people would be alive in this country. It's an abject failure. We feel it. And I feel it as a primary care doc at Rush. People can't get in to see me. I can't get people in to see the specialists. And it's a disaster. And to think that this is normal or acceptable, so organize. We have to organize This is a central issue in the United States, and it's risen again, and you feel it in your everyday practice. You feel it, I feel it, and the patients feel it. It's awful. And there's no other way to say it. It's a broken system, and it's falling in on itself right now.
So I know there were a couple other questions. I know we're at time. I love the fact that you're here and you're willing to stay. I don't want to abuse the time of our panel, but if they're willing to stay. But I also do recognize there are other events that started about like 20 minutes ago. So that's why some people have run out, and if you have to go, go. Let me ask you, can you take one or two more questions, or do you have to go?
No, it could take, but I would say breakfast is way more important than this.
Well, there will be food still downstairs, and at 11 o'clock, there will be mac and cheese. Okay, so maybe you have a question and you have a question? And then we'll wrap up.
You kind of covered mine.
Oh, yeah. Did you have a question, or are you going to? No. Oh, yep. All right, one more question. Thank you.
Excuse me for my English though. I was raised in the UK, but thank you for the opportunity.
Can you move closer to the microphone?
Yeah. Thanks for the opportunity, because I have been here for a couple of weeks now, and I just love the energy of Oak Park people. So I do have a question, like, what's your take on does building a stronger community leads to quality of life?
Does building a stronger community lead to quality?
Building a stronger community leads to high quality of life?
Does building a stronger community lead to higher quality of life?
Yes.
Would you care to elaborate on that at all?
Okay, so I realized there was something wrong with not being a doctor of medicine, but the way the whole thing was structured. And I began to sort of dive into what makes a healthy community and what makes an unhealthy community. And there's certain things that help, this is back to the loving community. If you're in a loving, healthful community that has purpose and meaning, individuals live longer. It's quite an amazing phenomenon. And that actually health outcomes start with well-being and trust. If you have mistrust and if you score low on well-being scores, communities have worse health. So we've got to get to that idea. That's why I loved what you said about a loving community, because yes, there's great evidence that when you have communities that have higher well-being. Now let me talk about what I mean by well-being. So when the grocery store in Garfield Park closed under the cover of night, in the past no one would have done anything. We organized a table. When that life expectancy gap I talked about, when we realized that, how did we not know it, right? It was our community health needs assessment right out our back door. When the pastor said the last shall be first, that community had been passed over, like Passover, passed over for capital investment by the city's Invest Southwest program. We wanted to do a quality of life plan, and we got passed over. We realized we did not have an organized table led by the community, nothing about us without us. So we spent time to create a collaborative. It's called the Garfield Park Right to Wellness Collaborative. And that work of community organizing is something called collective efficacy. So if you think about, we are all born with human potential. That's all the same. And it's not the obstacles that get put in our way keep us from achieving our potential. And but that's our human capital. And then what we have between us is social capital. We know each other from other things. We've met each other. So I can lean on you. I could call you up and say, hey, can I borrow a cup of sugar? Mm-hmm. Right? You will say yes because I'm your neighbor. But when you do it all together around a table, it's something the sociologists called collective efficacy. Neighborhoods that have higher collective efficacy have better health and well-being, lower homicide rates, even with the same poverty rates. So there's something about building healthy communities. It starts with this loving community idea, and it starts with cohesion, building social cohesion, building social capital together, collective efficacy. When the grocery store closed in Garfield Park, we had enough collective efficacy to organize demonstrations. And then to get, and this is medical students and people from Garfield Park, and to get the city to then invest in that neighborhood in a grocery and affordable housing. And I think that that sort of idea, and this is what makes Oak Park so great, right? People come out on a Saturday morning to hear something. It's collective efficacy. We have a lot of it. And if that thing builds community well-being. So when you look at the life expectancy in Oak Park, it's a lot driven by the social capital we've all built with each other. Doesn't mean we always agree, but this cohesion builds health. But if you deplete, if you extract from a community the wealth, if money doesn't come into the community, which is you need money. The cure, Pastor Hatch said, the cure for poverty is money. Let's not get fancy here. But when you deplete, when you extract, that's why I don't like the word disinvestment, it's extraction. When you extract so much, you extract the ability of me to even walk next door and ask for a cup of sugar. Mm-hmm. And so that's, this idea of well-being has everything to do with healthy communities.
Thank you. Thank you all. I know we didn't get a chance to talk about, we all got to talk as a large group, which was good. I just want to lift up a couple of points before, I want to thank you all very much. Oh, I have a lavalier like thing. And a couple of things that stuck out to me that I hope everybody heard some things that you'll take away. One of the things I really appreciated though, and I want to lift up, especially as we're in Black History Month, which is, as many people know who know me, probably my least favorite month of the year. And people say, why is that? And it's like, well, because a lot of the time we spend in Black History Month, I frankly feel we spend a lot of time praising ourselves for no longer lynching people, which is good. Lynching people is bad. But there's so much more to do, and we point to how far we've come, how good we are, how well-meaning we are, and one of the things I love that you lifted up was how structural this is. It is good to be good people. It is good to be nice to people. It is good to know your neighbor. But so much of it is built in that if we just do what the systems say, we will be caught in that system. If we just follow the metrics,